Hi, good afternoon, everyone. My name is Dr. Dominic Akatiba. I'm with Ghana Medical Help. This afternoon, we are bringing you a webinar, which we are partnering with Humanity First Ghana in collaboration with the Humanity First UK. These are a household name group of people, usually who work in the Upper West region, supporting both the municipal and regional hospitals in terms of capacity building, equipment donations as well, and mostly in the obstetrics and gynecology and pediatric units. We've brought them on as part of our maternity service agenda, which has been ongoing for the last 3 years. We run weekly webinars, usually at 3 p.m. in the afternoon, most of which have been led by local experts, consultant gynecologists, specialist obstetrician gynecologists, as well as some residents in obstetrics and gynecology. We are privileged this afternoon to be led on this webinar by Dr. Mashood Saeed. Dr. Mashood is a consultant obstetrician and gynecologist at the New Cross Hospital at Wolverhampton in the Midlands in the United Kingdom. He's a senior consultant with vast experience in a specialty for more than 30 years. I bet a lot of us had not been born by then. And he's worked as a consultant for 22 years, was with the Royal College of Obstetrics and Gynecologists tutor, and was responsible for the junior training program. He also has been an examiner for fifth year medical students, just like it is in Ghana. We run fifth year mostly in obstetrics and gynecology and pediatrics. And he's been with the University of Birmingham Medical School. One of my great mentors as well has been with the University of Birmingham, Dr. Edu, very popular in Ghana, here, a nephrologist. So we are grateful, Dr. Saeed Mashood, for this time that you can make with us. And just to alert participants that this webinar is being recorded and it will be put on our social media handles as we always do, so that those who cannot join for one reason or the other can access it. As well, those maybe with network challenges typical of developing environment could access it if they do encounter some network challenges as well. So stay tuned, and that will also be available. Kindly note that once Dr. Mashood starts his presentation, you will be unable to unmute yourself. This is to prevent people from either advertently interrupting the presentation by unmuting themselves. However, the chat box is opened all throughout the presentation. Kindly put in your comments, questions, contributions in there. And at the end of the presentation, we'll have some good time to go through this. Also take note that at the end of the presentation, then you could electronically raise up your hand and I'll be happy to unmute you to make a contribution to this presentation or ask a question or make this more interactive than just one person presenting. Thank you so much once again for joining us. Dr. Mashood, over to you. Thank you.
Assalamu alaikum warahmatullahi wabarakatuh. Peace and blessing be upon all of you. As you heard, my name is Maqsood Saeed, and I'm working as a gynecologist and obstetrician. I've been doing it for many years. So today I've been given responsibility by Humanity First and, of course, your hospitals to get on with the topic, which is very, very basic and controversial as well, I would say, in obstetrics, because the CTG, fetal monitoring, fetal well-being, and fetal look after starts, and the basic principle of monitoring babies, a CTG. Although I'm sure you all know that CTG is not absolute sensitive and accurate to give us 100% knowledge. In fact, there is no process where we can be 100% sure about the great or normal outcome of the baby. So all sort of monitoring can help us, but that doesn't mean that there is a 100% guarantee that baby is absolutely normal and will be delivered fine. So the objective of our my presentation today is um uh, identifying the fetal monitoring, um, and why do we use fetal monitoring in labor? Any guess, anybody? I think because you're all on mute, probably I have to answer all these questions myself, but interactive in future we can do. So electronic fetal monitoring is a screening tool, remember, for hypoxia. It's not a diagnostic tool. So we always try to monitor and screen babies who are in labor. How do we detect fetal hypoxia in labor? Any idea? I prepared that way as a lecture, but I will answer myself. Currently, we use fetal movements. I'm sure you do ask moms about fetal movements, electronic fetal monitoring, which are external normally with Doppler. We do scalp stimulation testing. When woman is in labor, we sometimes examine and stimulate by touching the baby head during vaginal examination. And when we are monitoring the baby CTG, we see the response. Uh, the fetal blood sampling is done to check hypoxia. Uh, the ST segment of CTG, which is done in combination with the external monitoring, is uh, uh, monitoring, which is actually hardly used. Very few selected uh, places use this sort of monitoring, but it is not very popular because it should be used in combination with CTG and ST segment of the baby ECG. And then single transabdominal listening to the fetal heart is another method which is used for uh, external monitoring in low risk pregnancies. So there are limitation of all the monitoring. As I said previously, CTG independently is 60% false positive rate, which is massive. 60% means there may be an abnormal CTG, which will actually baby will be absolutely fine, but CTG may be abnormal. So that is the limitation of the surveillance of CTG. So all surveillance method requires mainly awareness and recognition of the risk factor. The whole picture should be taken, including any reviews, how risk factors can be impact on the decision making. The other limitation to CTG interpretation are the skill, judgment of the person or person. You know, when there is a CTG, the new midwife is looking at it. She may be not that experienced. Even senior midwife may miss things, or junior doctors are called to review the CTG, and they may not be very experienced with CTG. Before the consultant involvement, there's a time delay, and errors can take place, and that is where the problem arises. So let's look at the errors. What errors can happen? Um, So, timely detection of the fetal hypoxia is the most important way of looking and preventing problems. Um, I imagine, um, as probably you know, that error in CTG monitoring in interpretation is something which is always concerning. A number of reports have identified common themes in errors made in interpreting the CTGs. All the reports featured here in the UK found similar trends. The reports also identified the failure to recognize transition from latent phase to first stage of labor and monitoring of fetal heart approximately. So basically, what happens when when we are recording uh, baby uh, labor, they are in initially latent phase, so they move to active phase, and that active phase is missed, or they are start latent phase can be prolonged, can be up to 24 hours. So a patient may have moved to active phase, and changes may have happened, and it has been not noticed by the midwives who are actually monitoring the mother and the baby. So I'm sure you are aware that in this country, in the UK, there is a massive medical legal price for this. And I think last year about 466 million in claims were awarded only for 300 claims. So imagine 300 patients sued the trust and they were awarded 466 million in claims, which is a huge money. Uh, so we fail to recognize abnormal CTG when the CTG is showing the changes. That is the next step. When there have been changes in the CTG, the people who are looking after the CTG, they will miss the abnormality. And then the next step, if they have see there is an abnormality and they have missed it, they may have seen it, but they fail to act because there's a process of noticing abnormality and then you react to that. Means if the midwife notices something and it's abnormal, she needs to report that to senior midwife, and then senior midwife need to involve the medical staff. But sometimes they see the abnormality, but they fail to inform seniors and medical staff, and that's where things can go wrong. Um, so they won't call the seniors or doctors, and even the junior doctors may not call their registrars and consultant because they feel that things are okay, but it may not be okay. So the problems have all these problems when they are monitoring this or watching the CTG and watching the baby during the there has been incidences where the CTG of the mother heartbeat is being placed on the Doppler, and it has been mistaken as a fetal heart, and baby has been dead for uh, days or sometime for hours. So now the new monitors specifically have two different readings. One is for maternal heartbeat, and the other one, one is for a fetal heartbeat, and the other one is for the maternal pulse, so that you can differentiate. And if there is any doubt, previously we were trained to check the maternal pulse with the CTG when there were no maternal pulses on the CTG machines. Okay, so um in UK, and I'm sure it should be everywhere um, around the world, the documentation should be taken and taken properly. The documentation of assessment of the mother and the baby should be clearly documented with date and time. There are a lot of documentation we see where midwives or junior doctors or people who have seen the patient fail to write the exact time, because in obstetrics and CTGs, timings are the most important. Delivery of a baby only few minutes late can result in fetal ischemia, brain damage, and a huge loss to the parents, as baby may be handicapped, and financial loss to the trusts. So I've mentioned about this, about 466 million um, pounds were given to the patients and their relatives for the only 300 baby who had poor management during labor. So it's not only the money, it's, as I said, the effect on the parents, effect on the relatives when the baby is born abnormal, it has huge consequences long term for the families. So we need to see and make sure how we can make the maternity safe. And the key message is from all these reports which were collected and published is safer maternity care and set a national target to have reduce or half stillbirth rate. The stillbirth rate is falling, but there is still more work to be done in UK. The staff care for women in labor are required to undertake annual training and competency assessment in CTG and use of auscultation. So the auscultation is for low risk, but they have recommended that all the staff who are involved should have annual training. Um, the midwife, the obstetric staff, junior doctors, consultant. So actually, we all consultant have to go for annual training for the uh, this induction and prompt aid, and it's run by midwives sometime, although consultants are running it as well. So it's once a month, um, because our department is very big. So it's once a month training for all the staff, which is booked in advance. So we 40 uh, um, junior doctor, midwives, and consultants take part in that, but it's monthly, so everybody is accommodated over 12 months. So once a year is mandatory for every consultant. So I'm just going to now discuss about the normal CTG and what is a normal CTG. So in UK, it's 1 centimeter per minute is the speed on the machine which is set um, all over the country, and that is how we deal with the CTG um, and read the CTG, because reading CTG, there has to be a standardized way of dealing with it. So I'm just putting an actual CG picture here, which I will just briefly introduce. I'm sure most of you know about the uh, basic features of the CTG. So cardiotocograph is basically um, you can see the baseline is the first thing which are so the analysis of a CTG. If you see a CTG for 5 or 6 or 10 minutes, excuse me, that's not sufficient. You have to have a 20-minute CTG to give a full opinion and assessment for this CTG, whether you can label it as a normal or abnormal. So the baseline heart rate for a CTG is between 110 and 160, and that's considered normal. So anything which is, you can see here, that's the baseline, and that's very much normal. Then you see uh, that the gestational age is very important. Remember, a 25-week baby heart rate will be quite high because sympathetic system develops late, and baby may be having a higher heart rate, and you may see that as a tachycardia. But gestation of the baby is very important to know. And later on, full-term pregnancy baseline is between 110 and 120. So that is for the baseline um, heart rate, a most important thing. So then the baseline tachycardia is considered when the heart rate is above 160 continuously. So this is very much normal. I'll show you next another CTG, the tachycardia, where it is constantly, this baseline is gone. You can see here is 140 and there's 160. So if this baseline is gone up somewhere and it's staying there, it's will be abnormal heart rate. So baseline should be below 160 and above 110 all the time. So what things can increase just the baseline maternal temperature can increase baseline. Um, and also it's important to make sure you look at the CTG, previous CTG, and see what was it looking like. The baseline was 110 and this baseline is now 140, although it's within the normal range, but it is gone up. So that is a change. You need to keep an eye on it. And you have to look, as I said before, you have to look at the bigger picture. Um, so bradycardia is defined as heartbeat drop of 15 beats for 15 seconds, and if it goes below the baseline of 110. So if the baseline is staying 110 here, and then it goes down for 15 seconds and comes up, it will be recorded as fetal bradycardia. So this is very important to first understand the um, normal CTG, and then you will be able to look at the abnormal CTG. The baseline variability is five or more, and which is this small up and down going. So if it's less than one, it is not right. It should be more than five. So it should be all the way up and down all the time. And this is five or more baseline variability, which is considered as normal variability. So acceleration is the fifth component. Acceleration is these towers you can see going up and then coming down. Oh, what happened? I need to go back. So the acceleration you is this is the baseline, and then baseline it goes up for 15 seconds and it's coming down. So these are accelerations, and this is acceleration again from the baseline, which is here in this CTG, um, and it's more for more than 15 heartbeats for 15 seconds will be considered acceleration, and this is always considered to be a good sign. So remember that acceleration, baseline variability, acceleration of 15 beats um, from the baseline for 15 seconds are a good sign, including baseline variability. So they say rule of 15 is very important to remember. Um, Deceleration when the heartbeat drops from the baseline, and that is when it is for 15 seconds and 15 uh, um, a drop in 15 heart rate of 15 beats. So if it's going here on 140 and it comes down to 125 and then it goes back to this in a V shape, that will be considered deceleration, and that is associated with hypoxia. In next few slides, I'll explain there are variable deceleration and late deceleration, and they have different significance. So um, when there is variable deceleration, that is nothing to worry, because it could be just for the time being, which has no relation. It just happened one deceleration here and there, and it's not significant. The significant deceleration are associated with initially with contraction, which is called type 1 deceleration, and then the next one is late deceleration. So deceleration are actually reflex response to protect the baby myocardium. When the fetus is exposed to hypoxia, they are there are early variable and late deceleration. And as I said, it depends on contraction frequency and strength of the contraction. So I'm going to uh, tell you that in a second now. So this is just a normal CTG, reassuring CTG, which is showing normal baseline. Baseline variability is more than five. There are acceleration and there are no deceleration present in this CTG. So this would be labeled as reassuring normal CTG. Okay. Now, if you look at this CTG. This CTG is showing a baseline of between 135. Yeah, it's about 135. If you can see here, this is the baseline. There are accelerations. Baseline variability is okay in this part. This is 10, this is 10 minutes, and this is another 10 minutes. But if you look at this here, this is reduced variability. The variability is less than 5. It's like a just variability of 1 to 2. So it's just going up and down for very little time. And reason for reduced variability can be a lot of benign causes, like nothing to worry. Like reason would be some maternal medication. Uh, Maternal medication, if the patient had pethidine, baby will go to sleep. There can be um, if the mother has been taking some sleeping medication, or they are on um, epileptic drugs, the variability will be reduced, but that will be reduced all the way from the start. But if a baby has showing a normal, beautiful CTG, and then you give pethidine and it becomes like this, that is fairly okay. There's nothing to worry because that is normal. Another thing which is physiological is baby after being very active, like in this part, second part, there is sleep pattern, which is normally baby sleep for about 15 to 20 minutes and then is active for 15 to 20 minutes. So if it's a sleep pattern, that's where we use external method by giving sometime mother cold water, ice, or do a vaginal examination and stimulate baby head to see if there are changes in the CTG, and baby wakes up, and then we say that's fine, baby is asleep. So that is things which we can do. So prolonged reduced variability will be associated with hypoxia, and that's the first line. Um, if the baby is small baby, like 32, 34 weeks, and baby is exposed to hypoxia, the nervous system will respond more, and the reduced variability can be indicative of hypoxia in premature babies. Loss of variability is sign of decompensation. So initially, baby tried to compensate, but when uh, it's a prolonged reduced variability, the baby is unable to cope, and the heartbeat is staying down, and patient is unable, baby is unable to cope with hypoxia. So you have to look into other things. Okay. And next slide. So as I said, a deceleration is defined 15 beats drop in the baseline. So if you look at this deceleration here, it's just actually a mirror of the acceleration. If you just put this CTG upside down, these two, both of them, they will actually look, they look here as a deceleration, but if you put it upside down, they will look acceleration. Let me go back here. So this deceleration is a mirror of actually acceleration. And if they are associated with contraction, so when there is, if you look at this, this is a tachograph. When there is acceleration, there is a deceleration starting. So strength of the contraction going up, deceleration starting, baby heartbeat dropping. That is called early deceleration, which is associated with um, head compression of the baby, which is vagus nerve stimulation. So it doesn't indicate fetal hypoxia. So you should be very clear that there's nothing to worry. Maybe patient position is changing, patient baby head is going into the pelvis and it's compressed by the contraction. So they after that the CTG is fine, variability is good. You may see acceleration. So it's just associated with head compression. Now come the variable deceleration, which is this one here. So variable deceleration is uniform, usually mechanical. Fetus, fetus will cope with it very well, and just they can become deeper, as you can see here in this second one, and they can be of varying shape. And if they continued, there you need to look at the concerning feature, which could be early signs of baby compromise. So the variable deceleration happens with baroreceptor response, like compression. Um, uh, there's a feature called shouldering. An absence of shoulder. I will explain in a second what is shouldering. When babies responding and compensating, there is a shouldering, and then that is pretty okay. But if there is a loss of shouldering, that is concerning feature. So absence of shouldering, biphasic, loss of variability within deceleration, slow to recover to baseline, last more than 60 seconds is concerning. Okay. Um, so the third type of deceleration is called late deceleration. And if you look at here in this slide, you see there is a uterine contraction, and when uterine contraction is finishing, the deceleration is starting here. So that is why it's called late deceleration, because it's at the end of contraction. And the late deceleration, as I have mentioned here, it occurs after the contraction. So late deceleration is a chemoreceptor mediated response to the fetal hypoxia. Hypoxic environments leads to chemical changes in blood, stimulates the chemoreceptor due to uh, change in pH, fetal heart drops, the contraction ends, the placenta venous sinuses refill with the fresh oxygenated blood, restoring the chemical balance, allowing the recovery of the fetal heart. This slower chemical response, which is why recovery is late, always indication of hypoxia is there. So usually it is accompanied by other signs of hypoxia, such as reduced variability. If you look at this, it has come back, but the variability is very reduced. It's less than 5. It's between 1 and 1 to 2. This variability on this side looks okay, but this is not okay. So it is having late deceleration with reduced variability. So that is concerning feature. Okay. So deceleration, early deceleration, nothing to worry. Variable deceleration, you need to look at things, other things, and see what is going on. And then the late deceleration is concerning feature and worrying. What you need to know about other deceleration. So this is called salutatory pattern. Now, this pattern is very unusual. It's very difficult to know what and why it happens. The pathophysiology is still not completely understood. And you can see uh, it is showing deceleration, which is similar to hypoxic deceleration. It reflects instability of um, patient heartbeat. Urgent intervention may be required sooner if pattern is seen during the second stage of pushing. So, to improve fetal oxygenation, consider stopping oxytocin infusion and maternal pushing. Give fetal chance to recover. So, this is very rarely seen, but this is something which you should act and try to switch off the syntocin on. Ask patient to relax and see if the CTG goes back to normal, and then you can commence pushing again. So we need to understand the basic physiology of the baby heart and understand some babies do not cope well with the labor, especially fetus at risk. So, as you know, most of the babies are healthy and fine, and they are low risk and they do well, and there is no issue in delivering them. So as I said previously, the bigger picture needs to be seen. A baby with IUGR at 37 weeks is not the same as a healthy 37 or 38 weeks. So IUGR baby have reduced and has reduced reserves and can end up in complication. So uh, So if the baby is healthy, normal, or his HP will be fine, he will have more affinity to O2 and he will be able to have efficient fetal circulation system and perfusion will be good and he can cope with the stress easily. Um, so the important bit, as I said previously, fetal heart rate should be maintained between 110 and 160. And if heartbeat is within the normal limit, it will do a rapid distribution and oxygenation will be pretty good. Um, so, as I said, clinical whole picture is the most important bit, and that will make you decide what to do and what to act. Um, So placenta, the respiratory organ of the babies, got sinuses, they have got pools, and they have gas exchange system, which will help a healthy baby to cope with minor stresses, which is normal for labor. Next slide, please. So the important is to recognize those baby at risk. They will not have the same reserve as I said before. Baby who are healthy will cope with minor stresses. Um, every single fetus has its own unique individual fetal reserve. Need to be vigilant on the um, patient as for the baby reserve as it is compromised or not. Why do the above risk factor affect the fetal reserve? So as you see, the preterm, postterm, fetal growth restricted baby, oligohydramnios, meconium. If there was no meconium in the beginning and then it develops meconium, it just suggests that there is something happening with the baby during labor. If it's an old meconium, that is irrelevant and that is not concerning during labor. Baby who had a pre rupture of membrane and has been like that for time, they are at risk of infection. So you really need to keep an eye on risk of infection during labor. If a woman had an intrapartum bleed, the placenta may not be in the best situation, and you may need to be a bit more careful with these deceleration. Diabetic baby have reduced reserve, so you will not be pushing the diabetic baby too hard during the labor. And if there are any compromise, you should be considering delivery them sooner than the later. If the patient has been on oxytocin for augmentation of labor, that is something which you have to be careful. It should be titrated with the contractions. 2 to 3 contraction per 10 minutes is considered fairly normal. And more than that can result in baby hypoxia because, as you know, that baby oxygenation take place in diastole. Temperature during labor, a change should uh, be considered. If they don't respond to a one standard dose of paracetamol and temperature stays up, you may consider giving them antibiotic if the delivery is imminent. But if there is no change and labor may take another 8 to 10 hours, you may consider delivering the baby by cesarean section. So when you see healthy baby, what would be you looking for? Baseline is normal, normal variability and cycle, no repetitive deceleration. That is what you are looking for, which is you can see here. This is a beautiful CTG of a healthy baby. Um, you can see that. Sorry, what happened? Yeah, so this is baseline is a normal. There are repeated acceleration going up 15 beats per coming back to normal. There are baseline variability, and there are contraction, which is 3 in 10, which is 3 in 10 minutes, which is considered fairly normal. 2 to 3 and 10, as I said before, should be fine. So this is absolutely healthy looking baby with no evidence of any hypoxia. Okay. So what happens when there is a hypoxia in a well baby? These are adaptive mechanism in response to hypoxia. A well baby will compensate for so long until it decompensates. The fetus will protect the myocardium at all costs. So fetus cannot increase its respiratory rate like we adults do. If we are going up the hill and we are actually heart rate goes up, but we can't increase. We can increase respiratory rate as well, but baby don't have these reflexes and cannot do. What baby does is what will happen, the heart rate will slow down and deceleration will start, which is what we don't want. There is redistribution of blood. That's how baby is coping now. And the supply to the essential organs will continue in this situation. If hypoxia continues, hormones like catecholamines and adrenaline is released to increase the heart rate, to increase oxygenation. This requires energy. So glycogen is broken down to release glucose, as we normally know, and this protect the myocardiums also. The glucose metabolism is always anaerobic in babies. So signs of decompensation will appear. It will no longer be able to maintain the steady baseline. The cycling may cease. So the CTG will show variable deceleration, reduced variability, and the heartbeat will start showing deceleration. Um, Initially, it will show tachycardia, but then because it is trying to compensate, but then I'll just show you in the next slide that after such an changes, if they last for prolonged time, what will happen? I have mentioned all these that heart rate will increase to protect myocardium, and there is a redistribution. So myocardial blood supply sometime increased to up to 500%, which is a massive increase, and a baby will remain stable there. Um, so when hypoxia continues, there is a decompensatory response. So this CTG will look like this. You see this CTG compared to this CTG, these are all accelerations and no deceleration and variability. So if I turn this CTG upside down, it will look like this. You see, these are all deceleration. You can see there are not many accelerations. Sorry, not much uterine contraction. The variability is just, this is like a straight line. It is going down and down, and it's dropping to about 70, and then it's taking very long time. So when they are getting wider, that is slow recovery, and this baby is not very happy. It is just baseline is coming to okay 120, but they are deceleration which are taking going very deep, and taking very long time to come. This is called shouldering. If you see this, when it comes down, it goes up and it goes above the baseline. So this is called shouldering. This is a good sign, but this baby is desperately in need of help. There is reduced variability, baseline has come down, and this baby is trying to compensate, but there is where we see this because of shouldering of the deceleration. So normally this sort of baby can respond to conservative management, which would be uh, basically um, you switch off the syntocinon, you can give her oxygen, you change the position of the baby and see if the baby respond to it. So um, now this is the next stage of this baby who was trying to compensate. But if you look at this, if hypoxia is ongoing, what the CTG will look like, you can see here, it looked like a CTG, it is decompensating. So the baseline has been lost. It has gone up. You can see it's gone very high. It's above 160. The baseline variability is lost, and the there is now this is initially you see this minute the baseline has gone up, there are deceleration and variability is lost. There's a prolonged deceleration. And what is the next stage? The next stage is look at this baseline, it's dropping. This baby is unable to compensate. It's just not responding to anything. And if you continue and don't do anything, this baseline will keep dropping and dropping. Where it was a healthy baby at 140, the baseline has come to 100, if you see here. So, although if you see that part of CTG independently, you may think it's fine, it's just acceleration, and there are baseline is about 110, but actually, this you have to, as I said, see bigger picture. Bigger picture means you have to see whole of the CTG, an hour before CTG and current CTG. Previous one was very healthy and nice, and this one is basically baseline is dropping, baseline variability is going down. And if you see the uterine contraction, it's hyperstimulated uterus. So even sometime after stopping syntocin, uterus was constantly contract, and there will be fetal compromise and hypoxia. So how does acute hypoxia happens, and what are the causes of acute hypoxia and why it happens? Well, sudden drop in baseline heart rate, a single prolonged deceleration is acute hypoxia. And why it happens? Uh, it There are so many reasons for it. Major causes are cord prolapse, abruption, or if patient had a previous C-section, a scar rupture can be the cause of this acute prolonged deceleration, and you need to exclude that. Check for the scar tenderness, examine and make sure there's no cord prolapse, and there is no vaginal bleeding, and there's no evidence of any abruption, which will rule out three major causes of acute hypoxia. So then, if baby is dehydrated or mom is dehydrated, you have to change the position of the mother. Back should be always on bend and on the left lateral position. If she's on syntocin on infusion drip, stop that. And if there are prolonged, sustained contraction, you can feel it manually. Excuse me. Then you can give tocolytic medication, but you should be careful with tocolytics because it can result in um, uh, basically making uterus so soft and it becomes unresponsive to the syntocinon, which can cause sometime abruption, bleeding, or failure to progress, and labor may not continue with even syntocinon. So very small dose of um, um, sympathomimetic drugs are given normally. Uh, we can give her as a spray, as an inhaler, or a subcutaneous injection as well. So, when you're seeing acute pyrexia, what actions are required? It is how to diagnose it. There's a prolonged deceleration, which is, as I said, you need to look at the causes, and those three causes needs to be excluded. So, sorry. So this is what is recommended by the NICE guidelines and the Royal College. What you have to do within 3 minutes, you have to exclude the causes, um, and uh, with 6 minutes, if the bradycardia is staying and there is no response from change of position, stopping syntocinon, excluding all, and doing all the standard measures, then woman should be prepared for theater, or if she's fully dilated and head is visible, for instrumental delivery. So you should consider delivering baby. And if the bradycardia stays and nothing responding to your conservative management, you should be taking patient to theater within 9 minutes. So this is 9 minutes rule, which is medico-legally very important, and documentation is very important. When that happens, the team who is looking after need to have somebody who is documented when they are doing actions. So you need to act with this prolonged hypoxia, which can save baby um, life, and also the medical legal side of the problem, especially in UK. So when there is a gradual uh, hypoxia, uh, you will get a chance to respond to it. So there are deceleration, loss of acceleration. If you look at this CTG, I don't know, can you see that CTG? Deceleration become wider and deeper, a rise in baseline, reduce or increase baseline variability, and unstable and progressive decline in the baseline. That is very typical CTG, which I'm just going to put it on, which is here. So if you look at this, the CTG is showing deceleration, which are here. You can see reduced variability. The baseline is gone up here. It's touching 160. Baseline variability is not there, and you see the progressive worsening of the CTG. That's 1540 and that's 1550. Or here you can see the baseline variability is gone, baseline is gone to 60, and there's constant deceleration repeated. Baby is struggling. Baby is really struggling, and it is happening over a period of time. So you need to find most likely cause. This is probably, if you look at this one, CTG, you can see the uterus is contracting every minute almost. One, two, three, four, five, six contraction or seven contraction in 10 minutes. So it's almost one a minute, which is too much. There should be um, two to three good contraction every 10 minutes. So the management for this sort of CTG would be stop uh, uh, oxytocin or reduce whatever dose she's getting, avoid, change the position, start IV fluid, and give her some tocolytic if required, if it's a hyperstimulation. If you have reduced the syntocinon and his contraction are still going on, then you need to reduce the syntocinon dose and maybe stop it. Okay. Um, Now, this is chronic hypoxia, which has been diagnosed probably in antenatal clinic. Patient presented for some other reason, and she may have said, "I'm not feeling baby movements." And when their is a CTG done, it is showing no acceleration, reduced variability, and deceleration. And this woman may be in early labor. It's just tiny, tiny contraction, and nothing is much happening here. So this sort of CTG is associated with um, a patient who would be having an IUGR, or maybe some baby compromise, uh, reduced liquor, patient who has been uh, born to somebody who is themselves have got a very low weight, and this baby is small for gestation, and all these sort of things are actually associated with an antenatal CTG, this sort of thing. So it's a chronic problem which has happened previously, and this baby is not very happy. So there are shallow deceleration on this CTG, which is this here. They should be noticed, they should not be ignored. Over here is shallow deceleration. So careful, consider what is going on, plan intervention, and increase. If you do intervention, make sure baby is mature enough, and or there is special care baby unit where baby can be transferred. So if there are no improvement, there should be a low threshold for delivery of this baby. Uh, the low risk patient, this I'm coming almost to the end of the my presentation. The low risk patient, which are basically have uh, statistically second pregnancy is the lowest risk pregnancy. First one, um, we have a screening antenatal appointment. Well, first appointment is screening appointment, and there is a midwifery led deliveries in all UK hospitals, where we screen them and we assess them. And if they are a low risk patient, then midwifery led care is the place where they would, if they would like to deliver under midwife, they are delivered there and looked after there. So intermittent auscultation is something which is basically for only low risk patient, where they listen to the baby heartbeat, which can be either by Doppler or the fetoscope. Fetoscope is becoming a little bit out of fashion now, but Dopplers are used, and baby heartbeat is heard for a minute to 2 minutes minimum, and it's just every 15 minutes you listen to the baby heartbeat. There's no CTG recording, and every hour the fresh eyes, which means another midwife will come and have a look, have a listen, and then they will reinforce what first midwife has done. And it is continued in the second stage as well. Um, and you know that with second stage, when mom is pushing, there could be some bit of deceleration at that stage, which is not much significant if delivery is imminent. It's just because of baby head compression. So as I said, so auscultation should be for at least 1 minute. It is showing deceleration, um, and it is after a contraction. So that is uh, okay for just a short time. Um, so if the baseline is there, there are accelerations, unlike to be concerning. But if there is increasing in the baseline, then you need to take caution, and you have to change this patient to fetal monitoring and continuous fetal monitoring, and maybe medical staff should be involved. So the intermittent auscultation is a very important and intelligent way of assessing this baby who is considered to be low risk. Um, Acceleration should be important for the well-being of the baby, and contraction monitoring is important too. So you should be very careful with this auscultation management, um, because it cannot detect variable deceleration, and also cannot all the time find the acceleration as well. So important is to keep monitoring and look at always at the bigger picture. If the Likert volume is okay, progress is good, and the CTG is showing very much no concern, and it has been a healthy, normal baby throughout antenatally, then you are doing fine. Any concern, there's no harm getting help from the seniors and medical staff. So I think I'm done with my presentation. It was about CTG. I think it's a art. It's not really, although it's science, but it's mostly art. And with time and experience, you slowly learn these things. And I would say that once a week, the staff, midwife, doctors should get some CTGs and discuss that in once a week teaching sessions with their consultant, so that's how you get better and better in diagnosis of abnormal CTG. So I think I will say thank you, and if you have any question, I'll be very happy to answer them. So I'll ask you to come back to me uh, with my camera on and my what you call slides on the there as well. So, right. Okay, so thank you very much. Are you all there or?
Yes, absolutely. Thank you so much. We are on, and all throughout the presentation, Dr. Mashood, we've had very good numbers of people turning up for the presentation. We've had a maximum of 153
Wow.
participants and a minimum of 98. Average numbers of 138 that we've had throughout your presentation. So really quite a good number of people joining in. As we talk currently, we have 135 participants online who are listening to you. So guys, like I indicated at the beginning of the presentation, if you have any questions now, you could kindly electronically raise up your hand, and then I would unmute you to ask a question or make a contribution. Thank you. Just as we wait for that, I draw your attention to a message I put in the chat box, because there's a first question that is coming up from Godson. Is saying that, can I have a video recording of this presentation? Yes, Godson, and everyone who would want to have the webinar recording of this. If you go with me to the chat box, you realize I put in the directions to getting these. This will be put up on our YouTube channel. So kindly click on the link that I've put in the chat box, and you would have the recording of this, as well as all our weekly webinars that we have done. If you also want to know what is next for our presentations, we have a WhatsApp channel, we have a Facebook page, we have a LinkedIn account. So whichever social media handle you prefer, kindly just click on to any of those links, and you will definitely be hooked on as to getting the webinar recording. And if Dr. Mashood is okay to send the slides as well, we'll make those available too. Otherwise, you have the webinar recording. So thank you, Gosson, for asking that in the chat box. Any questions, please? Kindly electronically put up your hand, and I'll be happy to unmute you to talk. Uh, Great. Kobna Deborah, please kindly go ahead with your contribution. Deborah, I've asked you to unmute yourself. If you could kindly click on the unmute button, and then you'll be good to go with your contribution.
All right, Doc. Yeah, thanks so much. I had interest in joining this, and I'm very glad that our resource person has really helped us to appreciate some of these things. Although I'm not a clinical person, devices we have here in Ghana, the recorder speed is set at 3 centimeters per minute, and he said in UK it's 1 centimeter per minute. I don't know. With this difference, is there anything probably we might be missing in our recording here? I'll be glad if you could probably throw some light on that. Thank you.
Thank you for your question. Can you hear me?
Yes.
So the standard for the 1 centimeter 1 minute is the standard in UK. In America, it's 2 centimeter per minute. You can do it 3 centimeter or 4 centimeter. It does not make any difference. But remember a couple of things. Whatever you are using, you should be aware of all the definitions. So when we are seeing 15 beats per minute for 15 seconds, that deceleration will look massive on 3 centimeter per minute CTG because your paper is rolling very slowly and it will be massive. So your response need to be accordingly. So that is one thing. Second thing is all these CTGs which I am showing or which are on the machines, it is for the local use. So if you are using 1 centimeter per minute, you are basically saving the paper. You are still doing the same monitoring. You are doing still the same. All the definition which are in the textbook, British and European textbook, are according to that measurements. So if you are creating a new speed on the machine, I'm not sure about Asian machines because I think I brought some machines to both hospital and I adjusted them to 1 centimeter per minute, which means you are basically 1 compared to 3 centimeter, you are saving the paper and you are doing exactly what is required. Similarly, if you want to assess any literature, any support, you can look at the same standards which are EU or in England. So in that way, it is always good to stay with standards. It's always good to save paper. It's all because in UK it's medical legal and we keep the CTG for 17 years for medical legal purposes. So that is few reasons where we do 1 centimeter per minute recordings and we use that speed all the time. And the textbooks and all these are used that way. So we are used to that. 3 centimeter is, I haven't heard, but in America they do 2 centimeter. Americans can do whatever they want as they are doing right now. Did I answer your question or is there anything else you would like to ask?
Yeah, so Deborah, if you have a follow up, you can unmute yourself and then go ahead. As well, if anyone has any question, contribution, or otherwise, kindly electronically raise up your hand and then I'll be happy to unmute you to talk. Yeah, so Deborah has put in the chat box that he's happy with the response to the question. So thank you, Dr. Mashood. We wait for any further questions from anyone. Don't feel shy. Kindly electronically put up your hand and I'll be happy to unmute you to go ahead with your question or contribution or suggestion. Thank you.
I think it's Friday afternoon time to go. Everybody
Absolutely. Absolutely. Yeah. So
long week.
looks like most of the people are good to go. And yeah. So yeah, I see in the chat box Dr. Ahmad is saying peace be unto you. So peace be unto you too. And he's saying, do we have midwives attending? Absolutely. More than 50% of the participants are midwives. Yes. So we do have midwives attending as well.
Just
Yes.
one question from my end. Do you use CTGs regularly now in both hospitals, or are they still limited use?
I can speak for the municipal hospital. I know for the regional hospital, they do. So if there's anyone from municipal hospital OBGY team uh, with a response, kindly electronically put up your hand and I'll be happy to ask you to respond or you could put it in the chat box. Yeah, so I see Pfizer is put in municipal hospital has a CTG. Yeah, but we're asking about regular usage. Having it is one thing, putting it to use is the other. So can you confirm if this has been put to use? Dr. Velda, yeah, please go ahead with your contribution. Thank you.
Okay, thank you very much. A very great presentation. I had insights into a lot of things that um, we probably overlooked, like chronic hypoxia and all that. But I know the CTG is a screening tool, and it just tells you that this fetus is a jeopardy from hypoxia. And in Ghana, we don't do the fetal scalp blood sampling. So, is there anything else you could do to confirm what's going on? Or you just have to section? Because sometimes we get a lot of um, good outcome when the CTG was ominous. So, is there something else we can do aside the fetal scalp blood sampling, especially in labor situation?
So,
Thank you.
good afternoon. Thank you for your question. So I did mention that you have to look at the bigger picture. There has been studies where the NICE guideline and Royal College have said that without fetal blood sampling, only CTG performed can increase the rate of cesarean section in units where they don't use fetal blood sampling. So it's not only C-section, but instrumental delivery increase rate is also associated with no fetal blood sampling. Having said that, I understand the limitation which you've got over there, and I think bigger picture. I was mentioning it repeatedly that bigger picture is where you would look at other things like if this is a low risk pregnancy, is there any risk factor with antenatal care? Did she have recurrent bleeding? Is she diabetic? Did she have any infections? Is there any other issue? Is the baby clinically looks very small? So all this needs to be considered. Then when she started labor, you need to look at her CTG and compare in 6 to 8 hours when she's say 8 or 9 centimeter or fully dilated to that CTG. What has gone. What are the changes? Like heart rate is still the same, baseline is okay, variation is still the same. There is no deceleration or very real deceleration. Meconium color is important. So if she started with clear meconium, no clear liquor, no meconium, nothing, and then there is fresh meconium. Meconium is grade 1, 2, 3, and 4. So if it's a very little meconium and the rest things are okay, it's nothing to worry. And if it was a healthy normal pregnancy, that's fine. But if there are other factors, you have to look at everything, assess it, and then make a decision, that whether this delivery need intervention or it should be continued. So I do understand that fetal blood sampling is not there. It is helpful, but you can reduce the instrumental and cesarean section rate by looking at everything, by assessing and being, you know, um, uh, using wisdom and experience, and that's how things happen. And it was like this in UK as well, when there was not fetal blood sampling available in every unit. It's mandatory now in UK to have that if you are having a CTG. So that's what I would suggest. Thank you.
Okay. Thank you very much.
Great, fantastic. Thanks as well. Uh, any other question? Otherwise, I think, yeah. Dr. Velda, is it a legacy hand or you didn't drop your hand after asking the question? Okay, great. So, any other person with a question or comment? Otherwise, then, yeah. So, Dr. Ahmad, please go ahead with your contribution. I've asked you to unmute.
Peace be upon you. Thank you. Can you hear me, please?
Yes, please. We
Yeah,
can hear you now.
thank you very much, Dr. Maksud, for a very educational session. I trust that it will go a long way to impart knowledge in the clinical practice. Just want to suggest if we can have some sort of laminated sheets where you set the normal CTG and abnormal CTG the aid memoir, putting alongside wherever the CTG machines are there as a quick reference for those who are monitoring. That will be great help. We do in pediatrics, so that sort of thing, that's really helpful. Thank you.
So that's for the hospitals in WA, isn't it? You would like to have these laminated normal CTGs and maybe some CTGs as like early deceleration, late deceleration, and all that sort of thing, fetal tachycardia, and if they can be laminated and put it on the wall so that when midwives are looking, they can look at it, and the risk factor may be included. So if there is a big chart with CTGs and risk factor and everything put next to the CTG machine, that may be helpful for the staff to look at a quick reference to the CTG of the patient. I would say this is a good idea.
Thank you. Thank you, Doc.
Great, absolutely. I think it helps, just like we have usually with the various protocols that have been laminated and put in. So, yeah, thank you so much. Any other question? In the chat box, I see some few comments in there from one from Patricia. Well, he says Municipal Hospital Nandom CTG is down for 3 years now. And Balebe Abiba says no CTG at Babili Polyclinic. And Pfizer says Municipal Hospital has no CTG. I thought you had earlier mentioned that the Municipal Hospital had one. Okay, so she was saying that the WA Municipal Hospital has no CTG. Okay.
Excuse me. I think we only recently left a machine with the CTG. In fact, couple of machines, and we did some training sessions on them when we were there. And I thought they are using. We used the CTGs on few patients there when I was there last time. So what has happened to that machine? We need to find
Yeah,
out.
so yeah, Faiza Abdullahi, could you kindly unmute yourself and then let us know? Is it one municipal hospital you mean, or which municipal hospital do you mean? Has no CTG. I've asked you to unmute yourself. Yeah, Faiza, go ahead.
Salam alaikum.
Walaikum salam.
Alaikum
For
salam.
my knowledge, I haven't seen a CCT machine around, and I've been in the hospital since 2022. I haven't seen one in use. I think I should find out from management if there is any because I haven't seen one. Thank you.
Okay, thank you. So maybe if you can find out if that is, and it will be good definitely to have that put to use if you are there and then you don't know about it. So kindly contact Dr. Mansoura. I know, I'm sure you know Dr. Mansoura to ask about the CTG machine that was donated to the municipal hospital and which the training was done last year. So let's hear an update from you in our next meeting how that goes. Thank you. Any further questions? Okay, in the chat box, I think there are just two questions, and then we can call it a day. There's one from Zipporah. Laura Municipal Hospital has a CTG, but no one to train the midwife, so it's not in use. Yes, Zipporah. So some of these lectures are important for that, and definitely is good that you are bringing this up because the team usually comes to the Upper West, and so definitely it will be good to invite some people from Laura into WA for the training, or have some of the staff go over to Laura to have practical training on it. As well, those who are trained at the municipal hospital, we could have them do a scale down of the training. So Dr. Mansoura and the group that were trained at the municipal hospital early December last year, and Dr. Zach, who is the obstetrician gynecologist in the hospital, could have could help with that. So we'll send them messages as well, and then they can see how to plan such a training, because it should be ongoing, continuous ongoing training, so that then a machine is not donated and only packed in the stores and not be put to good use. So thank you so much for bringing that to our attention. Charlotte is asking, please, if you can share the record, then I'll be glad. Fantastic, Charlotte. So if you look in the chat box, I keep putting the link to the record, and that you could grab if you want. I'm just going to put it up again. So right there, I've put it up so you can have access to it via the link that I've put in there. Thank you so much. Yeah, so these are all the comments in the chat box. On behalf of all of us, local team right in Ghana, we want to say a huge thank you to Dr. Mashood Saeed for an excellent job done. You've really taught us as a consultant, and lots of people have been updated with their knowledge regards CTG. And again, it's been also highlighting the fact that some places have difficulties in having access to a CTG. As well, those who have access to it may have the machine and not have the adequate training, like in the case of Laura Hospital. And these are sometimes some of the secondary benefits that we get with webinars like this. Then it really throws light on the issues really at hand, especially when you have other hospitals also joining, like the Laura people have joined, like the Nandom people have joined, rather than if we just limit it to the municipal and the regional hospital teams. And so we are glad that this was done, and we are glad that it's been able to help lots of us. And like I mentioned, we had over 100 people, maximum of 150 plus people joining us for today. So really is well attended. We are grateful. We want to thank all the people as well for joining us for today. We're looking at having another webinar for this will involve the pediatricians. The topic we're looking at is neonatal jaundice, the management of it. Dr. Ahmad, who is a consultant pediatrician, is looking at doing that on the 17th of April, 2026. We'll get one of the local pediatricians, either Dr. Matilda Kanzum or Dr. Matilda as well from the municipal hospital to have to moderate that so that they can bring the local dynamics of practice into it. And we're hoping, because most of the times for us local teams, other hospitals that will not use this as their clinical meetings may not be able to join the morning ones. And so those who cannot will record and send it over through to you guys. If as well the consultant does have time and can make it like Dr. Mashoud has done today, then in the afternoon we'll have most of you joining. Again, that will also be recorded. So we are grateful so much to all our participants for joining in for today's presentation. Thank you, Dr. Ahmad, as well for making time to join this, as well as your contributions. And to Dr. Velda, everyone who made contributions today. Usually we keep saying that it is good to not to be shy, but to bring in the local dynamics. Let's know how things are, and I'm sure we'll contribute our quota towards saving the lives of precious women as well as newborn children. We are grateful. I see, please can the link for the recorded video be shared for revision? Again, I'll put it one more time like I've done throughout the presentation. So I've just put it in again. Kindly take a look at it and then we can close the meeting. Thank you so much, Dr. Mashoud. Thank you, everyone. God bless all of us. Bye-bye.
Thank you so much for giving me time. It was a pleasure to speak today, and hopefully see you next in a few weeks again.
Great. Peace be with you. Bye-bye.
Take care. Have a good weekend. Bye.